we have been pointing out, maybe we'll get this out of the way very, very quickly. We have a guest joining us from Trip Family Medicine this morning, but Russell Singleton, of course, is going to tell us that what we've been telling you for the last couple of weeks is that the boss is going away on a mission trip, and there's a few things that still are needed before they leave. And first of all, welcome back to the program. Oh, you know what, Russell? I've done that to you a couple of times before, and you don't want to shout, so we'll open up your microphone.
Oh, thank you very much. Good to be back here.
I was going to say the doctor and sons, and I guess the entire family are going, right?
Yeah, that's right. They're leaving in July for a 2-week mission trip, a medical mission to Nicaragua. And when they go down there, they're trying to take some hygiene kits with them. So we've been accepting donations at the office for the last couple of weeks. Really, anything that you would want to donate, I'm sure, can be put to use. But specifically, we're looking for things like Bard soap, deodorant, shampoo, conditioners in those little small bottles, toothpaste, toothbrushes, dental floss, laundry soap, fingernail clippers, all that small kind of stuff. And he's got two strapping young boys here that are trying to make some extra money and pay their way because it's not an inexpensive trip. So if you have a lawn that needs to be mowed, and I'm just going to throw this out there, toilets that need to be scrubbed, I'm sure they'll jump at that.
They're glad you're volunteering them.
Yeah, I don't think I told them about the toilet thing.
Well, we wanted to mention you've got a topic today that should be eye catching for most people, or at least ear catching today on the program.
Yeah, I've been thinking a lot about what we would talk about today because we've been on the air for over a year now, and so we've got an opportunity to talk about a lot of great things, and it is getting a little bit harder to think of things that are still relevant, things that we haven't covered, things that are still interesting, and so I got to thinking about something that I struggle with on a day-to-day basis in taking care of patients, and that is prescription medications, trying to manage and not necessarily manage the medical aspect of people's prescription medications, but to manage the financial aspect,
Yeah.
to help them find drugs that are number one, affordable. And again, we're not talking about efficacy or safety. We're talking about affordable. We're talking about drugs that their insurance company will pay for and not pull the rug out from under them because that happens, and we'll talk about that today. Um, the choice between a brand name drug and a generic drug and I wanted to get into that today, and I hope to maybe hear for some patients who've had some frustrations with prescription medications over the years.
I have my own testimony there as well because a number of years ago, my endocrinologist, that's not my knees, by the way, that's the microphone moving. They do sound similar, but she prescribed a medicine for me. And I had a copay with my insurance on just all of my other prescriptions, but I went to get this one, and the insurance company, because it was considered to be somewhat of an experimental treatment, didn't cover it, and I had to fork over $240 immediately in order to take this home. And when I told her about it, she said, "Well, okay." She said, "I've got an idea," and I said, "What's that?" She said, "We'll have the prescription the next time around." Well, it's still going to cost me $120 twice a month versus $240 once a month. But it worked and it was highly effective. It's just that I had to shovel all the money out of pocket for it.
Yeah, and I'll admit that is probably one of my failings as a provider. I don't really know with great detail what a lot of these medications cost on the other end. I mean, I wasn't trained in that aspect. I was simply trained to know what medications work, in what situations, how to safely prescribe them and manage them, and of course I try and be aware of price, and I am much more now than ever. But my chief concern is helping people and getting them feeling better and using whatever medicine is most appropriate. But unfortunately, that's not always the way it works because of you, as you have illustrated, the best medication may not be within reach. It may be ridiculously expensive. Uh, a patient and I were talking about a medication the other day, and he said, "Do you know how much this medication costs?" And I said, "Oh, I don't know, probably cash pay a couple $100." And he said 700 a month supply, so 30 tablets, $700. And that's not even the most expensive medication I've ever heard of. There are some weight loss medications that I'm just really excited about potentially using, but no insurance will cover it. and the cash pay price is over $1,000 a month. And even that's not a lot. If we start talking about chemotherapy drugs, really specialized drugs for certain autoimmune diseases, we're talking tens of thousands of dollars a month.
And for a lot of people, the choice is you do this or it's not like some. When I was prescribed years ago Pepcid, I remember after we got to generics, generics, your insurance company loves those. That's a lot easier. But some of these drugs were even near anything like a generic alternative.
But yeah, I think that's true. A drug will stay on patent for about 20 years. And then after that 20-year period, it quote unquote goes generic. And other pharmaceutical companies are free to create what the FDA calls biosimilar drugs. But the problem with biosimilar drugs is that even though the FDA requires that there's similarity and that for the most part they're comparable, they're not always the same. I think one of the biggest problems I have in that area would be thyroid medicine. Some folks just absolutely cannot take generic thyroid medicine because there are very, very small subtleties from one manufacturer to another.
Hold that thought. We've got more with Russell Singleton, physician assistant from Trip Family Medicine, on the way this morning on Better Health, right here on KLIX. It's 840. Russell Singleton joining us in studio this morning. He is a physician assistant at Trip Family Medicine right here in Twin Falls. And of course, the segment of the show is called Better Health with Trip Family Medicine. Bill Colley with you as well, answering telephones at News Radio 1310, KLIX, and newsradio1310.com. That telephone number, if you'd like to reach Russell this morning, 736-0300, 736-0300. I know for a while there was a lot of talk about prescription drugs being imported from Canada, but there were certain barriers because people were claiming they could get a better deal. At least it would be more competitive. Is that still the case, or are they still fighting that?
That's a great question. I don't know that I have a great answer to that. I do know that we see in Europe a lot of drugs being made available that we yet don't have here, and that's because the FDA has such strict requirements to prove or to establish efficacy, safety. It takes about 10 years for a medication to go from start to finish, from the R&D phase all the way through the three-tiered clinical trial system. So it's incredibly difficult to bring a drug to market and expensive too. It costs probably on average about $2.5 billion to take a drug through that whole process.
We have a caller joining us, and caller, just want to point out you're on the air with Russell Singleton on News Radio 1310 KLIX. Go ahead.
Good morning, Russ. I'm wondering if there's any help for these crack babies. I'm from Detroit, Michigan originally. My sister taught at Mumford Junior High, and she had crack babies. I know that the babies get hooked on drugs when they're in the mother's womb, but is there any help for some of these people that are on meth and crack and the crack babies?
That's a really great question. And I think some of that probably falls outside of my scope, but I can tell you what I see as a result. In family medicine, I see a lot of the mental health repercussions of that kind of thing versus the physiologic repercussions. And we do end up working with a lot of these kids in terms of pharmacotherapy, but also counseling too is a huge part of the puzzle. Not just individual counseling, but family therapy too, because the family situation is usually a mess, as you just stated.
And again, sometimes there are drugs that can counter some of the other effects that you can prescribe as well, but still we're rather limited in those areas because you don't want someone getting addicted to the alternative.
Absolutely. And I think at Trip Family Medicine, and I can speak for myself personally here, that we always try to keep people off medicine. We've got no reason or no incentive to put people on prescription medication. It's not like we're getting a kickback or anything. So all that we want is that people are healthy. Off the air, we were just talking about. I think you said it was a friend of yours or someone you had known in church.
Deacon at my church, yeah, years ago.
Who was being treated for hypertension or high blood pressure, and after losing a fairly significant amount of weight, he didn't need high blood pressure medicine anymore. And that is a wonderful example of how a patient can take responsibility and really affect significant change in their life and probably reduce the need for many different prescription drugs. I mean, diabetes, hypertension or high blood pressure, cholesterol. Think about smoking. Think about the different screenings for cancer that we have available. If we can get people on track with those, we can keep them from suffering those long-term consequences. And we just talked about mental health too, counseling too. If we can get people involved in that, there's probably a chance we can reduce their need to be on prescription drugs.
There are certain prescription drugs that I watch these. First of all, the people who manufacture them are trying to sell you on them. Ask your doctor. They want people to go in and ask about it. They're putting a little subtle pressure to get someone to bring this up. But some of these, when I sit there and I listen to the disclaimer at the end, the fellow talks really, really fast
Yeah.
and tells you that your toes, fingers, and eyes will fall out. In some cases, whatever it might be. But you hear this laundry list of side effects, and your first thought is, I'm not sure I really want that.
Yeah, that's what we call direct to consumer advertising. And I can't say that it's really been a helpful thing because on one hand, we get patients asking for drugs that they heard about on TV, whether or not they're medically appropriate. But on the other hand, we get people who are probably um, inappropriately afraid of a very effective and very appropriate medication because of this laundry list of side effects they've heard on TV, and they think that they're all going to happen to me. My fingers and toes will fall off. But I think what people misunderstand is a lot of times those disclaimers are more of a legal disclaimer than they are a medical one.
And that's because in a trial, maybe if you had a trial with 1,000 people, if one person had an adverse effect, this is the way they cover themselves with that.
Absolutely. If you're in a drug trial and you step off a curb wrong and trip and twist your ankle, it's going to end up as a side effect. You're going to have swollen ankle as a drug side effect.
What is the most, in your experience, frequently prescribed drug?
Well, that's a great question. In my practice, we see a lot of diabetes, we see a lot of high blood pressure. So I don't know. I think metformin is probably one of the more commonly prescribed drugs. Thankfully, it is generic. You're talking like $4 a month. And a lot of pharmacies will have, while we're on that topic, will have what they call a $4 list where you can get a whole host of medications covering various diseases for $4 a month. And that's probably with or without insurance. That's just the price. You can get a 90-day supply for $10. So anytime that we try and put people on medications, I know I, for one, try and start on that $4 list because there's some good drugs there. They're a little bit older, and I think there are probably some more effective, newer drugs with less side effects, but we're talking the difference between $4 a month and $50 a month. This year, we're going to see Crestor go off patent, and Crestor for the last couple of years has been one of the most profitable drugs, and I think it is a product of, I want to say, AstraZeneca, and for the last 10 years, they've probably been averaging $5 billion a year in profit, and it goes generic this year. Zetia is another cholesterol medication that'll go generic this year, and I just hope that they become affordable. I doubt they're going to jump onto that $4 list. Just because a drug is generic doesn't mean it's going to be cheap. It will be cheaper, but it doesn't mean it's going to be $4.
I can remember my dad when he had bypass surgery in 1986, which I don't think has changed too much. I don't think there's a lot of variation in the last 30 years in that. But afterward, he was he was taking 18 different pills a day. I was at his house one time, and he would put them in a cup and actually just tip the cup back and then wash them down with a little water for the absorption. And yet, within a few years, about 1992 or 1993, he went to his doctor one day, and the doctor said, I got an idea. And he prescribed a drug that had been used to treat something else years before. And it worked for my dad, and it cut down on his level of pills per day down to where he was maybe taking 4 or 5 from 18. And it was just because somebody realized in their own head, their own research that they had done years ago might apply to what he was going through at the time, and came up with some obscure drug, which was very cheap as well, too.
Wow, that's interesting. And sometimes we see that come out of the experience of medical providers. They just figure out that certain drugs have certain side effects that may be beneficial for other things. I think we've mentioned before that's how Viagra was developed. It was first developed for pulmonary artery hypertension, and then during the clinical trials, they started to collect some pretty interesting feedback, and all of a sudden, Viagra is born, and it's used primarily now for something else. But sometimes pharmaceutical companies, when they're looking to increase revenues, will actually take a drug that they've had on the market. They'll try and take it back to trials to expand the label because the FDA gives, I guess they give a what you'd call a green light on certain indications. And that doesn't mean that providers can't prescribe that drug for something else, but when they do that, it's called an off-label prescription, which sometimes is a pretty common practice with older, well-known drugs, but that can also be kind of risky business because if something goes wrong, uh, you're going to have to explain in court why you were prescribing this medicine outside FDA indications. And insurance is not going to pay for anything that's off-label, especially if it's a pricey drug. That's a easy out for them.
I was going to say, when you talk about what you're prescribing for people, and you mentioned diabetes cases, of course, we've seen a huge jump in all of those. But sometimes I'm sure that when someone comes in and they have an issue, it is the prescription itself. I mean, rarely, but we talked about side effects earlier, and sometimes you can switch them up, and by doing that, make them a lot more comfortable.
Yeah, I think so. And sometimes the insurance companies will force us to switch. And unfortunately, it comes down to dollars and cents. A couple of years ago, we saw one of the largest pharmacy benefit providers, Express Scripts, dump about 50 prescription drugs, brand name drugs, off their formulary. And it was just a dollars and cents thing. People who have asthma or COPD and they used a medication called Advair, they just woke up one day, got a letter in the mail saying, "We're not going to pay for Advair anymore. You need to be on something else." So we had to switch people to something different. Some of them successfully, a lot of them not. And then lo and behold, they add Advair back to their formulary a year or so later. But it's interesting that after Express Scripts did that, Advair's sales dropped by about $2 billion.
Wow.
So it's kind of frustrating, and I don't want to point fingers at anybody, but sometimes it feels like you're just part of this this big machine or this big game. Insurance companies, pharmaceutical companies are kind of haggling back and forth with you as the patient right in the middle. And as a healthcare provider, you're kind of right there in the middle too with that patient trying to advocate for them.
And people should recall too, your PA and your doctor in these situations, they don't often have that choice. And that's if someone is not happy about it, uh, obviously they've got to speak to the insurer versus the medical provider.
Yeah, unfortunately, we're losing more and more autonomy because of government regulations, because of the rules and regulations enforced upon us by insurance companies saying, yes, we're going to pay for this drug this year. No, we're not going to pay for that drug next year. And by the way, if your patient has such and such a condition, we're not going to cover any drugs for that. And some of that changed with the Affordable Care Act, but there's still a lot of areas where patients are just left high and dry. So we do everything we can to help patients afford their drugs. Again, there's that $4 list we try and use. We try and use copay cards if you meet financial requirements. A lot of pharmaceutical companies, to their credit, will have what they call patient assistance programs where they can actually give a lot of this medication away for free. We use samples whenever we can, but it is not as easy as just picking a drug and writing a prescription, that's for sure.
Before we wrap up today, for people, we know that your office is still looking for new patients and that you can often see a patient on the same day, which is a rarity in today's medical community. For people who'd like to get some contact on reaching the office, if they're looking for a new doctor or physician assistant, an office that might be a little bit more amenable to their needs, how do they get in touch with you?
Call us at 933-4400. The earlier you call, the better chance you have at getting in same day. We want to not only take care of you, but we want to take care of your whole family. We want to take care of your chronic health needs, and we want to take care of the small little stuff, life's little emergencies, like we call them.
Sometimes people wake up in the middle of the night with that subtle emergency, and one of my coworkers had that issue a couple of weeks ago. It was not too terribly debilitating, but it may have been something that he had to eat, and he needed the care of somebody in the medical professions very, very fast.
Yeah, for that, I've got Dr. Tripp's home phone number. If you want to grab your pen, it's 555. Go ahead and give him a call.
He'll enjoy that to no end, I'm sure.
I'm sure he will.
All right, we'll probably see one of you in the next week. It might be you again.
Unfortunately, I'll probably be back here in a couple of weeks, maybe more like a month. We'll probably get to talk to the doctor next week.
Well, Russell Singleton, we want to thank you for coming by this morning. Better Health with Tripp Family Medicine is coming up on 8:59. And, of course, Fox News is ahead in just a couple of minutes. We're going to talk city parks and recreation for a few minutes after the news this morning. And if you're ever planning to actually rent some space in one of the parks, how you go about doing that, and some of the events coming up this summer as well, with Parks and Recreation Director Wendy Davis from the city of Twin Falls. That's on the way.